I've been involved in discussing the concept of needs of new classifications for rare cardiovascular diseases, which is an hot topic related to the discoveries of a very high number of genetic causes for cardiovascular diseases that were not known before to be actually genetic disorders. And in this discussion, my major message was that we can't longer use phenotype-based classification, because all the big knowledge that we have achieved in the last 20 years is totally useless if we don't translate all this information in the clinical practice. And therefore I strongly support the hypothesis of development of new nosology systems that describe the phenotype and the cause of a disease. And we have a model already that has been supported by the World Heart Federation, and the model is called the MOGES. MOGES system is a descriptor that includes morphofunctional phenotype, organ involvement, because the involvement of organs other than the heart is common in genetic cardiovascular diseases. And then we have information about genetic or non-genetic, familiar or non-familiar disease, the E, which is for etiology, that specifies the causes, and finally S that specifies the functional status of the disorder, in particular of the cardiomyopathies. So this discussion has been useful and promising for future development and implementation of new nosology systems for rare cardiovascular diseases. One of the major contributors to the diagnosis of familial genetic rare cardiovascular disease is the family screening. The discussion on family screening versus family pedigree was actually very contributory, because it highlighted the importance of not relying only on the narrative of the patients in order to know whether or not a disorder recurs in the family, but we need to screen the patients and the relatives of the patients using non-invasive tools such as electrocardiogram, echocardiography at least, for cardiomyopathies, and I would say also for thoracic aortic aneurysm and dissection of genetic origin. In other words, for diseases that have major syndromic manifestation, we can be supported by just a visual perception on whether or not a family member is affected, for example in Marfan syndrome. But for diseases that do not have manifest phenotypical traits, then we need to go to instrumental screening, non-invasive instrumental screening of relatives. The proportion of familial genetic cardiovascular diseases that can be diagnosed with the screening obviously is much higher than the proportion of these diseases that are just diagnosed on the basis of a family history.